Hello, good morning, everybody.
Good morning.
It's my pleasure to be here. Thank you for the invitation. I hope everybody is okay. I will share with you our experience with robotic endovascular neurosurgery. I like to share the credit of this talk to my colleagues, Dr. Julian Spears, Tom Marotta, Aditya Barata, and with our robotic technologist, Nicole Cancelleri. Uh, when we speak about robotic endovascular neurosurgery, actually, it's sometimes a controversial topic. We don't know what to expect. Some people are afraid of robotics, that someday they will be so automated that we will not be necessary. I think I see it as an evolution, as a tool that we can use to our benefit, and as a tool that can actually assist us to perform consistent and reliable procedures. Uh, when we speak about endovascular robotics, there are actually two systems. One that is a navigation system that consists on helping you getting to the carotids and verts and inject contrast and do diagnostics or in the heart for coronary disease, and the robotic intervention systems that are actually the systems that can actuate and can perform the procedures under your guidance. And this is what we will be talking today. And there's only one system approved to do neuro intervention, and this is the Corindus neurovascular system. There are two other systems, the Sensei and the RoboCath, that are actually only approved and used to perform coronary interventions that we will not talk about in this conference. So the core path consists of two parts. One is the robotic arm that you see here on the bedside table. And the second one, part that is the console, which is a cockpit in this picture where it's completely leaded proof with a high definition screen and with controls that can actually control the movements of the robotic arm. And this control, the console, can be also outside in a different room. So this is a picture of how it looks like inside the same room. So the robotic console is here in the corner. You don't need to wear a LED because it's protected. And this is the position of the robotic arm on the bedside of the table. And this is a picture of the system mounted during a procedure. Patient is here, and we have the robotic arm and the robotic arm extension and the cockpit here in the corner. This is a closer view from the cockpit. So this is what we actually see when we are performing the procedure. This is the console, and you can see here 3 joysticks, one for each device that you can manipulate. One is for the microcatheter, this green one. The middle one is for the micro-wire, and the third one is for the devices. There can be coils, stents, intrasacral devices. And here in the monitor, you have 3 different sections that corresponds to each joysticks. So you have different functions here in the console that you can actually control as well the procedure, and you can control the device. And this is a closer view of how we handle and how we manipulate. And this is how the robotic arm looks like in live. And there is a part that is fixed, metallic, that is covered by a sheath. You can see here the plastic covering it. And you have a removable and sterile part that is called cassette, which is this plastic part here that actually you mount over the metallic part. And this is the part that every procedure you have to put it in and discard, because this is the part that is you have to use in every procedure. And the cassette and the robotic arm is composed by a small screen that the technologist control and operate. And the cassette itself has a placeholder for the micro catheter. You actually need RHV, which is a Y connector that is especially placed in the anterior portion of the cassette. And then you have two drives or paths. One is for the microwire. And at the end of the microwire, you have a rotational drive that can make loops and rotations. And you have a linear drive that can actually push and pull the devices from in the procedure. And every part, so microcatheter, microwire, and drive will have a specific joystick and a specific part in the console control to actually activate all those devices. So this is a video of our technologist showing how to prepare actually the console. So the robotic arm is there, and she's actually placing the cassette, which is a removable part. This is the RHV that is used, one of the RHVs that's called Copilot, that is used actually to connect the robotic procedures. And now in a procedure, in a recent ACOM mannerisms that we performed, we have here Nicole connecting the system that is already placed in the neck into the console. So this is for this generation of robot, we have to navigate and get up to the neck, to the cervical area. And then from that point, you connect to the cassette, and you can perform all intracranial portion of a procedure that requires one microcatheter and one microwire, and that is you can perform completely robotically. But the placement of the catheter and the positioning, you have to do it manually. And you see here the guiding catheter and the distal access catheter and all the system that is connected to the robotic arm. There is a sheath. There is actually a tubing that actually comes from the cassette over the micro catheter and connects to the RHV. And this is a system that actually can keep the micro catheter from kinking and why the robotic arm is navigating it. So this is a closer view of the system, and this is a closer view of the console. The console has also some special movements that we use during the procedure to facilitate the work on manipulating the robot. This is just a list of some. Let me show you here in this video. I have done PCOM coiling, and I am navigating to place actually the stent at the end. And you see here that to rotate my microwire, I actually use the function that's called rotate and retract. And you can actually, the robot grabs the wire and actually rotate it very fast. And it's a function in the monitor of the console that it will actually perform. And it actually can almost a one-to-one rotate the microwire at the tip. After the navigation of the microwire, we usually move the microcatheter distal. So in the robot, there's a function that's called active device fixation, which is a function that, as you can see here, the robot pinned the wire, and just by moving the microcatheter, you can actually navigate the microcatheter to the position that you want without the need to actually control the slack on the robotic, on the microcatheter. So this is a very useful function to navigate into this case towards a distal location, or if you have deployed a stent, to go back into the stent with your microcatheter through the wire of the stent. So we've performed a number of experiments before doing the first cases. And this is a picture of our actual first case that we actually performed a couple of simulation procedures before the procedure. This is a paper illustrating this robotic, experience before. And one of the first impressions of the robotic system was actually that the robotic system was very precise. And one of the main features of this generation now is that we can precisely place the stent in a location. And we have chosen this case initially because we thought that the robot would help us to achieve our planning. That was to place the stent below the bifurcation and then go inside the aneurysm and complete the coiling. So this is what we did. I'm not in this picture doing the procedure. I'm doing actually a model training. And we had done at that time already probably a year of experiments, tested the different systems, and have explored the potential and the capabilities of the robotic system. So this is actually the first case. So in the first row, you see here the models. In the second row, you see actually the case itself. And it was pretty interesting to actually do the case in the model, and was pretty reliable and very a very similar experience. We had a little bit of a difficulty to get into the aneurysm, although with a large neck. But once you place the stent, the microcatheter was always hooking into the struts. We had to torque the wire to get in, and the same difficulty that we had on the model we faced during the case, and the model experience, the previous experience, gave us the confidence that we would be able to perform. And this is the follow-up, 6 months, aneurysm completely excluded, and we have just recently a year follow-up, and this is the result that we have. And the robotic system in this case helped us keep below the bifurcation and actually place the stent exactly where we planned. I will share with you another case, a 67-year-old case, another sidewall aneurysm in the basilar, and a patient that had an aneurysm that was diagnosed small, but as you can see here, she had much bigger aneurysm in 2019. It had grown, and she had an indication for treatment. When we perform these robotic procedures, we actually evaluate access to understand how we can prepare the case for the robotic procedure. We have a 20 centimeter navigation length. So we have to place the distal access catheter in a position that we actually will be able to navigate and retract 20 centimeters. And this is the case. We had here a pretty tortuous proximal end. We have to place for a vertebral basilar aneurysm the catheter here in the distal V3 or early V4. And this is the picture of the DSA showing the aneurysm at the level of the ICA. And we have decided to perform this procedure through the radial. And we had planned to place it here in this position in V3. And then deploy a stent. And after deployment, go inside the aneurysm with the same microcatheter and perform the coil. So again, this current generation, we can only manipulate one device, one microwire, and one microcatheter. We have to place everything manual. And these are pictures from the procedure. This is the access being placed. We navigated as distal as we could with a Sophia 6 French. We try always to use 6 French catheters because we actually have a backup plan in case there's a rupture. We have always prepared a Scepter 4x11 or an Eclipse in case we have a rupture. We've never had, but we always have it in case we have a problem that we need to intervene. We use the Neuroform Atlas and Axiom Prime coils. And this is a video showing the perioperative imaging. And you can see here the navigation of the device. I'm now navigating the microwire. The video is fast forward. You see here that I move constantly from the joystick to the screen, which is a touch screen. I'm actually using a function that is called rotate and retract. Although the vessel seems straight, but actually it goes deep and up. And there's a pretty acute angle between the proximal portion before the aneurysm and the distal portion. And I'm actually navigating. This is the joystick for the microwire. This is the joystick for the microcatheter. And I'm slowly getting past this curve and now getting into the basilar, distal to the aneurysm, to place the microcatheter before the stent placement. I choose my procedures lately for the robot cases that actually fit into a trial that we've been including patients, but also cases that I actually think that the robot will bring precision. I'm here now changing. My team on the bedside, my fellow and Nicole had just switched from the wire, and she's now placing the stent, an Atlas stent, and you see that she's in the other drive on the side. And once they change, they give me back the control, and from the console, I start manipulating the robotic arm as well. So in this upper picture here, you see the movements of the robotic arm. In the lower picture here, I am controlling the robot, and on the side, you have the view of the procedure itself. So I'm actually advancing the stent. Initially, I was advancing with the joysticks, and now you see that I'm actually pressing buttons, and I'm pressing what we call millimetric controls. I'm actually pressing the controls, and every millimeter I am advancing the stent and pulling the microcatheter. This is the way I like to deploy stents. And the stent deployed precisely what I want. And after that, I navigate inside the stent with that function called active device fixation, or here, because of the tortuosity, I'm using the joysticks to actually get into the stent through the wire and then being prepared to catheterize the aneurysm. So inside the aneurysm, I remove the wire from the stent, the pusher wire, and my team placed the microcatheter, and I'm actually catheterizing the aneurysm. And the robot is very interesting to perform these tasks of catheterization. We can rotate the wire pretty with a pretty good control, and we can go past the struts. I'm here now placing the first coil. And it's, again, fast forward. I don't coil that fast. And here we have chosen a pretty long first coil, 3D shape. The stent is in place, sidewall aneurysm, not too complicated to go through the steps. So we progressively filled the aneurysm with coils. You can see here the progressive placement of different coils. And this is the end. Last coil is unable to place. I removed everything. And this is the perioperative angiogram, final control, and this is the MRI 4 months. So we've done also some other devices, although they are not approved to be done with the robot. This is a ruptured PCOM aneurysm in a case that had an occluded carotid, so the PCOM was feeding the MCA territory and formed this aneurysm. We coiled the aneurysm, and we also placed a flow diverter procedure. I'm actually placing a Silk Vista Baby, which is pretty precise, pretty good device to be placed using the robot. And you can control very well the placement, the slack, and the opening of these devices. This is the final angiogram. And this is some other cases that we did, some basilar cases, PCOMs. The last one was a flow diverter. And this is an experiment showing how we can actually deploy a flow diverter. This is an Evolve device. We did an experiment before the procedure that we used the device. And actually, you can control pretty well the deployment, particularly those new flow diverters that you can control very well the opening. This is a very good tool to deploy these devices. So we've done a number of distal locations as well. ACOMs, these are two ACOM aneurysms. You can see here with two lobules. And I like to show this case because the navigation can be quite tricky. We went through the right, and you can see here in live the navigation of the wire with the robot crossing the aneurysm that actually was taking all the ACOM towards the other side. We place the stent, we navigate the catheter through the stent inside the aneurysm. And this all done robotically. This is the final result. And we were pretty happy with the performance of the robot in these cases. And the robot is kind of a pretty, it's a system that obviously requires training, but it's a pretty intuitive system. This is my kids in one of my experiments.
Backward, faster, backward, faster. Okay, now forward, faster. Now forward, slow. Very slow. Yeah. Now backward, faster. Now backward, slow.
These guys have no training in endovascular, obviously. And I think if they will be smart enough, they will not be physicians to not be on call all the time. But they could control the robot just by seeing me and under my guidance. So it's a pretty intuitive system. It obviously requires training, but if you perform a procedure manually, you can do it robotically enhanced because you can be very precise and very controllable. So our experience today so far is 25 cases, 2 flow diverter and 23 stent-assisted coiling. And we've been rolling cases into the core path, the GRX neuro study. It's actually a study to demonstrate the safety of this procedure in multi sites. We have done 20 cases in this study, and we are ready to enroll 20 more from next week. So our current perception is that the robotic brings precision, radiation protection, but the future is actually to expand to remote. We know that access to stroke care, particularly in distances like Canada, United States, Russia, can be pretty tricky just because of the geographical distribution. This is the access to stroke care in Ontario, just small areas. And our plan is to offer or develop remote access care in the future. Hopefully, we will have the right technology to perform. And this is the plan that we have, as many of us also have the ambition to perform remote procedures. Cardiology is already there, but not diffusely. There was an evolution of the remote care, and one cardiologist performed 5 STEMI procedures in a 20 miles distance. There have been a number of experiments, but the future of robotics is certainly to improve the access to remote areas. And this is a picture of one experiment from the east to west coast United States. A cardiac simulated procedure was performed as well. And all different networks had the same performance. So it's just the matter of having the technology that with the technology, the transmission that we have today, we will be able to perform these procedures. To the question of can we do stroke with the system that we have now? The question is yes, but you need someone to place a guiding catheter into the neck. I haven't done a clinical stroke procedure, but I'm showing you a simulated procedure where, like the old times, we deploy a balloon guiding catheter, a flow diverter, a stent retriever, and we pull the stent retriever. But you will need a pretty advanced team on the bedside. So the future of robotics, particularly on remote, will require a system that can also navigate the catheter until the neck. And also certainly automation. Corindus was acquired by Siemens. That will certainly bring a lot of integration with imaging, and I hope some steps that we actually struggle to do today, like the access to the neck, will be done in an automated way. I thank my team that is helping me through this journey, and I thank you for the invitation. Thank you very much.